Hey everyone, so happy to see you here at ResusX Live. Today I'm going to be discussing ProCalcitonin, and I have to tip my hat to Haney for the title of this particular presentation, Con or ProCalcitonin. Definitely don't have hair as good as he does, nor am I as witty and charming as Haney is, but let's talk about ProCalcitonin today. First, I want to say that I do not have any disclosures with regards to this particular talk. One of the things I always want to get through first is where does procalcitonin come from? And basically we got to think about where all our biomarkers come from, because this helps us understand why we even look for them. Getting into the calc1 gene, this is a gene that's upregulated by different stimuli, like for example, an elevated calcium level, glucocorticoids, beta-adrenergic stimulation, etc. And within the thyroid, within the endocrine system itself, there is calcitonin mRNA that's produced. Then magic happens, and then this turns into procalcitonin. But this procalcitonin that's produced in the thyroid is not secreted into the bloodstream. This is why under normal situations, you should not have an elevated procalcitonin level. What it is turned into is calcitonin, and that's what we know and love and goes into the bloodstream of the patients. However, under pathological situations, for example, patients with elevated bacteria that cause elevations in lipopolysaccharides, for example, inflammatory mediators such as interleukin-6 and tumor necrosis alpha, these cause the stimulation to produce more procalcitonin in the adipose tissues. But keep in mind that things that cause inflammation cause an increase in procalcitonin. This is one of the reasons why, for example, burn patients have elevated procalcitonins. Patients with cancer at baseline have elevated procalcitonins, as well as patients who have end-stage renal disease. So keep that in mind, because here the same thing happens, but in adipocytes, for example, where calcitonin mRNA gets converted to procalcitonin, but here it goes directly into the bloodstream. And with this biomarker that's already been out for a couple of decades now, there are a couple of indications that we really look for in our clinical practice. And that is for the initiation of antibiotics, as well as the cessation of antibiotics. There are some other indications out there, but that's going to be too much going too into the deep end for the sake of this talk. The FDA has various recommendations of what we should do with these procalcitonin levels. For example, a negative procalcitonin level, basically less than 0.1, they strongly discourage giving patients antibiotics. 0.1 to 0.25, they discourage it as well, but now between 0.25 and 0.5, they recommend giving these patients antibiotics. When you look at levels that are a little bit higher, greater than 0.5, here they strongly recommend giving patients antibiotics if you're thinking of something like a lower respiratory tract infection. And so this has created this sort of dichotomy that bothers me to some extent, and that's part of the reason why Haney asked me to do this talk. I created content on it that was quite controversial, but a commonly seen thought process is that if the procalcitonin is greater than 0.5, people just assume 100% black and white, no doubt about it, that there's a bacterial infection. And if the procalcitonin is negative, that there's no bacterial infection in this patient. And we really have to look at the data here, because asking ourselves, can procalcitonin differentiate bacterial and viral pneumonia? Well, the data is going to tell you. So they actually did this study where they looked at over 1,100 patients, and you do see a difference in the median procalcitonin levels of viral versus bacterial infections. It is statistically significant. The mean procalcitonin level is 0.09 in viral infections versus 2.5 in bacterial infections. Sure, there's a difference. But the thing that one has to consider is all the outliers. There's so many patients who have an elevated procalcitonin level and they have viral infections, but then there are also patients who have a low procalcitonin level and they have bacterial infections. When you look at the different stratum of the PCT levels with what type of bug they found, you do find that in patients who have a procalcitonin level less than 0.24, you can miss up to 6% of bacterial infections, and we never want to miss bacterial infections in our patients. Then one other factor that you have to consider is that an elevated procalcitonin, you can see up to 20% of those patients have viral infections. So please keep that in mind, that it does not rule in and rule out infection as well as many people think. But the thing that really caught me about the study is that in greater than 50% of patients, the procalcitonin, even procalcitonin very elevated, no pathogen was detected in these patients. So it might not be as good as we think it is for this patient population. But let's quickly refresh some statistics, because under every test, you need to have some sort of diagnostic accuracy. So we all want to speak the same language here. Looking at the sensitivity and specificity of procalcitonin, we always consider the area under the curve, or the area under the receiver operating curve. And I go over this just so we all speak the same language. If the AUC is 0.5, it's basically like a coin flip. There's no discrimination whether the test is any good. If the AUC is between 0.7 to 0.8, that's something that's considered acceptable, moderate, not the best thing that we want for a lab test. Then between 0.8 to 0.9, this is usually defined as an excellent test, and our gold standard tests usually carry an area under the curve of greater than 0.9. That's considered to be outstanding. So when we actually take a look at these different trials that have looked at procalcitonin to differentiate between bacterial and viral infection, the AUC is not very good. It's around 0.7, and this was using that study on community-acquired pneumonia. Then when they actually looked at patients who have had all the criteria for community-acquired pneumonia, including a CT scan of the chest in the emergency department, the area under the curve is just 0.6. It's basically a little bit better than a coin flip. How much weight do you really want to put into this? They have done numerous meta-analyses and systematic reviews looking at all this, and when you jumble up all the data, the area under the curve is still around 0.7. So it's not as black and white as many people think. If you just use procalcitonin as a marker for, yes, the patient has a bacterial infection or the patient has a viral infection, you're going to miss a lot of patients. So the IDSA has come together with these groups and looking at these trials, and they say that procalcitonin is unable to provide reliable evidence to either start antibiotics based on the procalcitonin or stop antibiotics based on the procalcitonin. So one of the other things that happens, one of the other ways that we could use procalcitonin to help manage our patients is to figure out if it will help us with antibiotic cessation. And this is where we might have a little bit more data, but there is a big elephant in the room when you look at these trials. The first thing is that out of all these trials that I read, the best one had an adherence rate to the actual protocol of about 75%. A lot of times clinicians say, hey, I know better than this biomarker, I know better than this test, I'm going to do things the way I want to do. In addition to they had differing cessation protocols depending on the procalcitonin, how much it dropped, or what the baseline procalcitonin was on admission. All these things were variables that one needs to consider when implementing their own procalcitonin-based guideline. If you think your patient has a lower respiratory tract infection, you're in the emergency department, you want to know if checking procalcitonins on everybody would be something that's helpful. And this was something that was looked at in a New England Journal of Medicine study with a ton of patients, but when they looked at the median procalcitonin level of all these patients, it was 0.05. So basically, based on that number and FDA recommendations, they would say, hey, don't treat any of these people with antibiotics. But even with a procalcitonin guideline, they still went ahead and treated these patients with antibiotics, as you'll see. But they also checked it on day 3, day 5, and day 7. What they found is that despite most of them having a negative procalcitonin, they received an average of 4.2 days worth of antibiotics in both the procalcitonin guided group as well as the usual care group. So it doesn't really help to just check procalcitonins on everybody because you're not going to get some good bang for the buck. But when you look at the community-acquired pneumonia subgroup, here they looked at antibiotics received and length of stay and all those things, and it also didn't help in this patient population. So what they did is that they kept on following these patients for 90 days and up to a year and seeing if they had a difference in mortality. But when you looked at the subgroups of community-acquired pneumonia, COPD, asthma, and acute bronchitis, there was no help whatsoever in checking a procalcitonin. It did not help mortality in these patients at all. And as I mentioned before, there are multiple cessation strategies that exist. For example, relative drop in procalcitonin from the initial, drop from one check to the other, or an absolute value are all things that one can find in the literature. But when you do actually do these protocols, you do find that there is some shaving off the days of antibiotics that patients receive in critically ill patients, basically 1.26 days of antibiotics. But we are not finding in these meta-analyses a difference in ICU length of stay, hospital length of stay, or recurrent infections either. So, do these protocols really save patients' lives? And they've looked at this and found that it might actually help save patients' lives. And the whole postulation behind it is that since you stop antibiotics sooner, then patients don't get as many infections with C. diff, for example, or multiple drug-resistant organisms. And the odds ratio here, looking at it, is 0.82. I personally don't like when they publish using odds ratios because it makes it very hard to explain to audiences. But that being said, the subgroup with SOFA scores less than 8, these did better. One of the other recent trials looking at everybody, including non-critically ill patients, did find a mortality benefit, but this publication in the Lancet really irked me a little bit because the number needed to treat was 100. So that's a lot of people to treat to find a minimal benefit in mortality using procalcitonin. So let's look at some quick subgroups to try to tease out if we could get more bang for the buck by using this particular biomarker. Patients with bacteremia, these patients do better using a procalcitonin guided de-escalation protocol, 2.9 fewer days of antibiotics. If you use the subgroups of gram-positive bacteremia, patients with strep pneumo, as well as E. coli UTIs, you can really shave off a couple of days of antibiotics. Patients with known sepsis, here they have fewer infection-associated adverse events, which are defined as patients with C. diff, death from C. diff, death from drug-resistant organisms, or secondary infections due to these. They also have less in-hospital mortality using a procalcitonin guideline. They have fewer median duration of antibiotics, etc. Cost of hospitalization is also lower. Ventilator-associated pneumonia, you could also shave off a couple of days of antibiotics here. And one of the things that really, this is my only slide on COVID, but people use procalcitonin to rule out bacterial co-infections. Here, it does not work, guys. The area under the curve is 0.5. It's basically a coin flip. Looking at in patients with COPD exacerbations, we run into the same problem, an area under the curve of 0.6 of differentiating whether patients with COPD have a bacterial infection underneath. So to wrap this up, should we use procalcitonin for antibiotic initiation? I don't think the data is there. I don't think it's as good as we think it is. It's definitely not a coin flip. It's definitely not going to diagnose it for you. But where we might have a little bit of wiggle room to use it, especially in places that use a lot of antibiotics, here you could use it, but the data is more clear. But you just have to keep in mind that they're different protocols.